Hello, everyone. I am Specialist Huyn Trung Ba from the Department of Pathology. Today, we are going to look at a case titled The Ticking Clock, a Hidden Killer in the Blood. Our patient was a healthy 40-year-old American male with no significant medical history. He had recently finished a 6-month work assignment in Nigeria, notably taking 0 travel chemoprophylaxis during his stay. Exactly 7 days after his return flight, his illness began. The initial presentation was entirely nonspecific, consisting of fatigue, vomiting, and diarrhea. He was initially seen at a local clinic, given symptomatic care, and sent home. But 4 days later, his clinical picture worsened violently, forcing an immediate admission through the emergency department. When he arrived at the ER, his symptoms had escalated. He presented with severe chills, progressive weakness, a marked decrease in urine output, and visible jaundice. Amidst these symptoms, one pattern defined the progression. His fever reached 40 degrees Celsius, returning in a strict 48-hour cycle, a rhythmic signature of a specialized parasitic life cycle. His vital signs confirmed a body under massive physiological stress. His blood pressure was hypotensive at 95/60, his heart rate was 120, and his oxygen saturation sat at 93% on room air. Because vital signs alone do not reveal the exact underlying process, a comprehensive laboratory evaluation was ordered across 4 categories: hematology, systemic inflammation, hepatic function, and renal function. This is a 4-quadrant laboratory dashboard tracking the patient's results. Starting in the hematology panel, we see severe anemia with hemoglobin dropping to 7.0. However, the MCV and MCH remain perfectly normal. Because the cells are normal in size and color, we know this is an acute blood loss, not a chronic production issue. We can track that acute loss by looking at the elevated RDW and a massive spike in LDH to nearly 600. Combined with a collapsed platelet count of 48,000, the data confirms significant cell injury and acute hemolysis. Red blood cells are actively breaking apart. Moving to the hepatic panel, the liver is also failing. AST and ALT are elevated, confirming hepatocellular injury. Furthermore, a total bilirubin of 12.4 with a mixed direct pattern mathematically explains the patient's visible jaundice. Finally, the renal and metabolic panels show a BUN of 40 and an eGFR that has plummeted to 26, confirming acute kidney injury. A depleted bicarbonate level of 18 confirms concurrent metabolic acidosis. When we step back, we see that the anemia, the liver injury, and the kidney failure are not isolated diseases. The labs describe a single, unified intravascular event that is aggressively taking down multiple organ systems all at once. Faced with a febrile traveler returning from West Africa, we must build a focused differential diagnosis. This visual diagnostic funnel maps the 6 primary diseases we must consider upon presentation: yellow fever, dengue, typhoid, leptospirosis, babesiosis, and malaria. We can quickly narrow this down. Dengue and yellow fever drop off because the patient lacks retroorbital pain, rashes, or active bleeding. Typhoid and leptospirosis cause kidney injury, but neither produces a strict 48-hour cyclical fever. Babesiosis is a very dangerous mimic that causes hemolytic anemia and fever, but we can morphologically exclude it here because a review of the blood smear shows no Maltese class forms. This leaves malaria. The patient's travel history to an endemic region, cyclical fever, hemolysis, and severe thrombocytopenia make it the definitive primary suspect. The clinical picture has successfully narrowed our funnel, but we still require targeted laboratory testing to prove the specific pathogen before we initiate treatment. We rely on 3 distinct diagnostic tools. The first is the rapid diagnostic test. Its primary advantage is speed, giving answers in under 20 minutes for early decision-making. However, it cannot quantify the parasitemia, and false negatives do happen. This graphic of the cassette highlights 3 critical markers. The control line confirms the test is valid. The HRP2 line detects antigens specific to Plasmodium falciparum. Finally, the aldolase line detects antigens common across non-falciparum species. To go further, we use optical microscopy. This is the historic gold standard, allowing us to physically detect the parasite, confirm its exact species, and quantify the infection burden. Within microscopy, we utilize thick and thin smears. The thick smear lyses the red blood cells, concentrating a larger volume of blood into a small area. This maximizes sensitivity for parasite screening and detection. The thin smear answers a different question. By preserving the exact red blood cell morphology, it allows us to visually identify the specific Plasmodium species and mathematically calculate the percentage of infected cells. While a rapid test points us in the right direction, distinguishing the exact pathogen species and measuring its destructive burden absolutely requires these microscopic tools. To correctly identify the Plasmodium species under a microscope, we look at the size of the infected cell, the shape of the ring forms, and the structure of the gametocytes. Examining the patient's thin smear reveals classic Plasmodium falciparum. We see delicate ring-formed trophozoites, double chromatin dots, and multiple rings per cell. We also observe applique forms clinging to the edges, alongside crescent-shaped gametocytes, all within normal-sized red blood cells. By counting these infected cells, we calculate an estimated parasitemia of 16%. This is an extremely high burden, categorizing the infection as severe. Finally, a PCR test was performed to provide definitive molecular-level confirmation that the species was indeed falciparum. Identifying these specific morphological hallmarks provides the proof required to confirm a diagnosis of severe falciparum malaria, rather than a less lethal strain. The infection begins when a female Anopheles mosquito injects sporozoites into the skin. These travel directly to the liver, invading hepatocytes to silently multiply before releasing thousands of merozoites into the bloodstream. Unlike other strains, Plasmodium falciparum invade red blood cells at all stages, driving massive parasitemia and 48-hour fever spikes. The danger intensifies as infected cells develop knobs that trigger cytoadherence, gluing themselves to the endothelial walls and rosetting with healthy neighbors. This severe cytoadherence causes immediate sequestration. The infected cells form a mechanical obstruction, physically blocking the microcirculation of the small vessels. Once the microvessels are clogged, blood stops flowing to the surrounding tissues. This cellular blockade is what directly caused the massive tissue hypoxia, ischemia, and subsequent multi-organ failure we saw in the patient's lab results. The final diagnosis is imported severe Plasmodium falciparum malaria. Because of the massive parasite burden combined with rapid hemolysis and acute kidney injury, the patient meets all criteria for a medical emergency and must be managed in the ICU. In the United States, first-line management dictates immediate administration of intravenous artesunate at 2.4 milligrams per kilogram, dosed strictly at 0, 12, and 24 hours. Throughout this treatment, laboratory monitoring is critical. Thick and thin blood smears must be repeated every 12 to 24 hours to objectively verify that the massive parasite burden is actually decreasing. Once that parasitemia falls below 1% and the patient is clinically stable enough to tolerate it, the treatment protocol can safely transition to an oral ACT therapy. Time is the critical factor in severe falciparum malaria. By recognizing the clinical pattern of a ticking 48-hour fever and quickly trusting the morphological evidence under the microscope, we can intercept the disease and save a life.